What's going to keep you sober in the long run is being aware of how much better you feel. Your brain works better, your energy is better, your relationships are better. And so sort of emphasizing the benefits. So the people who do best participate in all parts of the program because you're changing a habit, you're changing behavior. And us humans, we're pretty stubborn. We don't like to change. It takes a long time to change. So what I'm doing is going to help you. But in the long run, it's the work with the coach and the other work that you do personally that's going to get you to where you want to be.
Good morning, everyone. Welcome to another episode of How's My Drinking? My name is Arin Gharapetian.
Good morning, and my name is Marcela Cabay. And today we have a very special guest with us today. We have Dr. Paul Lindy with us. And Dr. Lindy, could you just go ahead and do an introduction or just share with our listeners a little bit more about you?
Yeah, sure. So I'm a medical director at Ria Health for Psychiatry and Collaborative Care. I've been with the company for 4 years, and I am a general adult psychiatrist with experience in addiction medicine, but also experiences in other areas of psychiatry. And I came to the program of Ria Health via our chief medical officer and co-founder, Dr. John Mendelsohn. We actually have known each other for more than 20 years. Our kids went to preschool together. And he lives about 2 miles from me here in San Francisco. And so he was asking me to come work for Ria Health when I still worked at the UCSF School of Medicine. I'm retired from there. Medical schools are proprietary. They won't let you do outside work. So I told John, my hands are tied. I can't come. And then I finally retired during early COVID from UCSF, and the rest is history. I'm here at Ria. So.
Well, that was actually going to be my first questions, like what drew you to, I do want to know what keeps you passionate about the work that Ria Health is doing.
Yeah. So I've done a variety of work in my career, and I really in general, I like addiction medicine, and I'm very interested in helping people reduce or stop drinking. I think that the yield is so great in health benefit, even with a drastic reduction in drinking. And it's really great to work with patients who are motivated to get better. And that's one thing that really sets this apart from, unfortunately, a lot of psychiatric clinics. You have less motivated patients. And what I love about working with Ria Health is the patients are motivated. And even if they're not doing well, they're open to coming up with a new plan. So that kind of is what keeps me coming back, is seeing patients get better. And, and I do see the interventions that we do work for a lot of people. I mean, obviously, they don't work for everybody. So that's a large part of why I keep coming back and that I'm excited to do the work that we're doing. Also, the other thing I would say is the learning curve. When I started here, I was really not that familiar with treating alcohol use disorder. And so really pretty quickly, I got a lot of information, like they say, drinking from a fire hose, of really getting a lot of information about treating AUD. And we just keep, pushing the boundaries. I mean, we keep trying new things. Part of it's the leadership of Dr. Mendelsohn. He's a strong leader in research and really understands the research literature. And I think he wants to make sure we're practicing the most up-to-date prescription and then other modalities as well, not just the medication-assisted therapy. Mm-hmm. So that's what keeps me going, really, is seeing patients get better and then also just continuing to learn new things. And really not just from Dr. Mendelsohn, but from all of my colleagues. It's a really high-quality group of colleagues that we have here. We've really built a great team and really talented people with different strengths, different specialties, and different areas of expertise. And I see the way that I practice is not exactly like the way other experienced people practice. So there's a lot of cross-pollination among the different members of the medical team.
Yeah, I would probably agree with you on a lot of that. I think being here too for some time, I've really enjoyed working, with you along with other medical professionals that we have, and everyone brings their own level of expertise, which is great for Ria. And she's able to help a lot of individuals out. I think one thing I wanted to touch on too, you kind of mentioned, was the whole medication for AUD. So the reason I want to touch on that is I think a lot of existing members now probably had this question. And I think a lot of people, as far as just researching, types of treatments, they kind of look at medication in general, but they have a lot of misconceptions around it. Specifically, Naltrexone is one of the biggest ones, and obviously there's a bunch of other medications. So just kind of curious, like, how do you respond to people that have these misconceptions about Naltrexone, that maybe it might not work or it might cause more of an issue for me? What would you kind of share with them around that?
Yeah, I mean, I'm always open to people's concerns and questions. And, now that I have a lot more experience prescribing naltrexone really for the last 4 years, I can anticipate a lot of the concerns and questions. Common things that come up is, they're worried that the naltrexone is going to hurt their liver, for example. And it really turns out that naltrexone is really only not indicated in really advanced liver disease. So people with cirrhosis who are on liver transplant lists, and naltrexone is safe on the liver in all other patients. And then, of course, that the alcohol is much more toxic to your liver than naltrexone. So if the naltrexone can help a person succeed in reducing their drinking, they're reducing their harm to their liver. I think sometimes people also get a little confused because they're wondering if it's a controlled substance because it's a cousin of Narcan or naloxone. And so it does block opioids. And in fact, if anything, it's, can be used to treat opioid use disorder as well. I think a lot of people come in sort of not knowing how it works. And they're afraid that the naltrexone is going to make them sick. And I think they have it really confused with antabuse or disulfiram. So there are 3 medications approved by the FDA for alcohol use disorder. Naltrexone is one, Acamprosate or Camprol is another, and then the third is antabuse or disulfiram. And antabuse has been around for 70 years. It's a medication that blocks your metabolism of alcohol, and it literally will block it at the point where you'll have these chemicals called aldehydes build up in your system, and you'll get sick, a flushing reaction, nausea, vomiting, etc. And you get really sick if you drink on it. So I think a lot of folks come in thinking that it's antabuse, and so that's one of the things we always talk about when we start naltrexone. Naltrexone does have side effects. I mean, nausea is not uncommon, but what I always tell patients is like, that's not how we're getting the effect. If you come back and go, I was so sick to my stomach, I couldn't drink. My first thing is that's not how we want it to work. And if anything, we need to reduce the dose. What I tell people about naltrexone is when it works, it's really seamless. It's really subtle. And what I'm looking for is that I want you to take this medication and then come back at your next visit scratching your head going, I don't know, I can't explain it, but I'm not drinking as much. And then, and a lot of people will say rightfully so, is it because, I've dedicated myself, I'm motivated, I have a new mindset, or is it the medication? And it's like, well, it's usually both, right? I mean, because people need to change their mindset and change their habits coming in. But it's definitely the medication can work that quickly. So I always tell people when naltrexone works right, you have no side effects, and it really does change the way alcohol tastes. It changed the way alcohol affects you, and it's easier to put it down after 1 or 2 instead of, 6, 8, or 10. So people do have misconceptions. And then let's really acknowledge the whole other factor is that, most people would rather not have to take medication for anything if they don't have to. And I think it can be a bit of a hard sell to take medication for. And I think if you understand it in the context of traditional alcohol treatment, which has been an abstinence only model typified by AA, Alcoholics Anonymous, and 12-step, that the old school AA says, you shouldn't be on any medications. And so that they've changed over the years. Like when I was doing psychiatry, I had a lot of patients who were trying to reduce or stop drinking, and their AA sponsor would say, oh, you can't take antidepressants and be an AA. And I'd be like, wait a second, it's kind of apples and oranges here. And so that's old school AA. It's most places, it's much more flexible. But I do think, part of it is, I'd rather not take medication. And so part of it is just trying to educate them that, the other thing about naltrexone, it's not a lifetime commitment for most people. It can be transitional on the order of months to a couple years. And so that's always reassuring to people. It's like, and I tell them sort of what would be the timing for reducing the dose or going off. So I think people are also reassured by that it's not like blood pressure medicine that you might be on the rest of your life.
Yeah, I think some people too, like as far as a medication, it's become kind of readily available where physicians might prescribe it as well. And there's platforms out there that allow you to get naltrexone. I think they don't offer some of the things that we do. It's a little bit different. And nothing wrong with the way that they have it set up, but like we have medical experts like yourself, to your point, explain some of the reasons that you might see side effects. And we are capable of going and saying, okay, well, maybe don't do a full pill, do half, 1/4 or whatever it might be. And I think that's maybe another area that maybe some people tried it. They see the side effects very quickly, and then they assume this is not the medication for me.
Yeah.
But I think in general with any medication, right, a lot of times physicians will want you to start at a lower dose depending on the medication of side effects. And you actually kind of build that up in your progression as your body gets more accustomed to it.
So before I came to Ria Health, I did prescribe naltrexone, not a lot, but some. And I prescribe 50 milligrams to everybody. So naltrexone only comes in 50 milligrams. 50 milligrams is the standard dose. And, a handful of those people couldn't tolerate it. And like they took one dose and got sick to their stomach. I'm like, I'm done with this medicine.
Yeah.
So for me, at least, I've learned a lot from the experience of prescribing. So Dr. Mendelsohn told me, 6 months ago, he said, you always seem confident in your treatment planning. And he said, I think it's because you keep up with the literature, with the research. And I should have told him, it's like, no, it's having done this for 30 years. It's more, for me, I learned from experience and repetition. And you do hear the same patterns over and over again. So with naltrexone, we start at a lower dose and get people slowly up to the full dose. And then I also learned that some people need a higher dose in the long run. They need 75 milligrams, 100 milligrams, even 150. So for me, I think it's the repetition and the experience and also the collegiality. I mean, we're always discussing different cases in real time with, my colleagues now also have a lot of experience. So there's a learning curve. And I take very seriously. And I think all of our prescribers take the education piece seriously. And that's why they like working here, because they're not only encouraged to, it's like, that's the cultures. We spend time with patients and explain things. And that's a much more satisfying way to practice than just flipping pills out there and not having enough time to explain it.
Yeah. I follow a lot of forums, right? Even field of marketing for the industry. I try to see what they're saying or not. And one interesting thing that I have come across is, certain programs that offer medication only, and they kind of don't, they might have some sort of medical supervision, but not to the level that we do. I've seen people where they sign up for, let's say, a year program, which will probably give them a discounted rate on the medication, to later on find out that, wait a minute, I didn't need the full pill, right? So now, technically, if it was supposed to be half or a fourth of that, it's now where they have a year plus supply of medication, and they pay insurance more. Yeah. So I kind of seen that too. And I think that's where the interesting part kicks in, is you would identify and work with the patient to say, okay, this is what you need to start you off with. And then here's what we'll cover down the line. And maybe we might increase it, keep it where it is, or even decide to decrease it a little bit. Right. So kind of, I think it's different for every person.
Yeah. And then the other obvious thing that, maybe we should say aloud is the fact that we have such a robust program to pair with the medication. We've got individual coaching. We use a breathalyzer for accountability. We have online groups. We have content. And I do think that some companies really more or less just put the meds out there and don't have a lot more content. Granted, they're less expensive, but they're much less expensive for a reason. They don't offer much beyond the medication. So, And I love that. My first visit with patients, right off the bat, I'm going, the reason this works so well is it's the medication. We'll talk about the meds. It can help you with that. We'll help you be successful. But the people who do best participate in all parts of the program, because you're changing a habit. That's also my pitch, is like, you're changing behavior, and us humans, we're pretty stubborn. We don't like to change. It takes a long time to change. So what I'm doing is going to help you. But in the long run, it's the work with the coach and the other work that you do personally that's going to get you to where you want to be.
I do want to make sure that I ask you this in case our listeners don't know. I know we do, but they might not. We only spoke about naltrexone. But what if naltrexone doesn't work for somebody?
Right. So that's a great question. I mean, we have a lot of options beyond naltrexone, and not everybody gets naltrexone because it's not the right fit for them. So naltrexone works particularly great when people are actively drinking and want to reduce the amount that they drink. For people who come in are already abstinent and want to maintain it, naltrexone's not a bad choice. But for example, that's a situation where acamprosate or Camprol often has more utility than naltrexone. And as I mentioned, acamprosate is also FDA approved for alcohol. And so that it prevents sort of resuming drinking, and it helps people maintain abstinence. So that's a situation where people come in already abstinent that we often will go with something other than naltrexone. The other medication we prescribe very frequently is gabapentin. And gabapentin often is prescribed with naltrexone because gabapentin works in an entirely different way. So gabapentin is a super versatile medication. It's been around for 25 or 30 years, originally rolled out and tested for seizures. And so it gets on the market. The neurologists kind of go, we've got these 5 other meds that seem to work better. So it kind of did not get used a lot for seizures. So what happened is, as doctors, we're pesky sorts, and we like to try new medications for all sorts of things. And really what it's kind of come down to now is gabapentin treats anxiety, insomnia, alcohol withdrawal, and it plays an additional role at a certain daily dose to prevent people from having heavy drinking days. There have been a couple of big studies. So it's not FDA approved, but all FDA approval is somebody applied for it as an indication. But that doesn't mean there hasn't been research. And so gabapentin can be very helpful, particularly people who are withdrawing. So I want to make sure people understand we don't do detox per se. So if you come to me on your first visit and you're having, let's say, 8 or 10 drinks a day or more, I got to quit. I'm going to stop tomorrow. And I'm like, hang on a second. We can work with your goal of quitting, but let's take some time, maybe even a few weeks to get there. Because if you stop cold turkey, you're at risk of having a seizure or other complications. I don't want to go there. And frankly, I don't think it works as well to go straight to abstinence in many cases. What we have people do is reduce the amount slowly, kind of 10% or so every few days at the fastest. And then we prescribe gabapentin because gabapentin is a treatment for alcohol withdrawal. And we have people take gabapentin and sometimes other medications to sort of help them with the withdrawal symptoms so they're successful. Because a lot of people keep drinking to treat their withdrawal. Because alcohol withdrawal is kind of fight or flight. It's anxiety, sleeplessness, high blood pressure, heart racing, sweating, nausea. It's very uncomfortable. And drinking will alleviate it. So a lot of people, they in this vicious circle of drinking and having withdrawal, and then drinking to alleviate the withdrawal, and they drink more. And then guess what? The next day they got withdrawal again. So it's a way to break the cycle. So Naltrexone, Gabapentin, Acamprosate, and then we have other medications as well that we prescribe. One is called topiramate. It's a seizure medicine. Again, not FDA approved for alcohol use disorder, but it's been studied pretty extensively, and it does help cut craving. It's actually a good naltrexone alternative for patients who don't have the craving reduction with naltrexone that we're hoping for. A lot of times we will switch to topiramate. There's baclofen, which has a role particularly in people with severe liver disease. There's some blood pressure medications seem to help, clonidine, prazosin, and then there's even newer medications. And we do prescribe antabuse sometimes. So there are patients appropriate for antabuse. It's unusual. I've sort of figured out what subtype of patient will do best. And it's really, really interesting. It's the people who come in and go, I'm the kind of person who needs a hard boundary. I need to anticipate severe consequences because I've tried it the other way. I've tried to sort of just cut down and I always end up cheating. And so those are the patients that the last 2 or 3 people I started on antabuse came in there very, very clear. And I said, I just want to make sure you know what the risks are. But yeah, it sounds like you are that type because it's the anticipation of the antabuse that keeps people from drinking. And it's interesting. So we do prescribe antabuse as well. And then if the listeners know that naltrexone also comes in an injectable form called Vivitrol, which the shot lasts for up to a month. We do prescribe it from time to time. Sometimes barriers to Vivitrol would be cost. Your insurance may not cover the whole cost. And it's probably $1,000 a month or has been. And then also sometimes finding a place to get the injection. So that's another option. Mm-hmm. The great thing about Ria Health is that our medical leadership with Dr. Mendelsohn, he really, really keeps up with the research and he's always bringing in papers and studies. And he really is encouraging us to use the most up-to-date medications. So there's a lot of options beyond naltrexone. And again, it's, sometimes naltrexone doesn't work. It seems like it would be the best one, but for whatever reason, it doesn't work. But we do have options, and sometimes we use combinations as well.
It's really good to know that there are options and that they will be working with an actual physician that's specialized in this. Did want to ask you, because you mentioned earlier, you work in hospitals and emergency rooms and more like inpatient type of facilities. So what would you say the biggest difference is between like inpatient treatment for alcohol use disorder to something like Ria Health that is like telehealth and you don't have to physically go anywhere?
Yeah, great question. I think a few things. One, I mean, I think the most sort of, important one to think about is the fact that when you go to residential treatment for alcohol or substance use, it's going to strictly be an abstinence model. And with good reason. I mean, abstinence is the best. I mean, I shouldn't say the best, it's the safest, certainly. And, and being detoxed appropriately is important off of different substances. But basically, you're less of a partner in your treatment. In other words, you're kind of like, this is how we do it. This is what you're going to do. And I just anecdotally hear people who come to us who have been really turned off with their previous experiences. I mean, I hear this a lot, and both of you guys would appreciate this, right? Because, Marcela, you're in enrollment, and Arin, I know you've done work in the industry before, but I've had people tell me, I called this 1-800 number, and like they're yelling at me, and they're demanding these things. And essentially what they're doing is they're trying to get them to come to the program. And some people, it's the hard sell, the bad cop hard sell. Like, these people are traumatized, so they're, for help. So I would say the main difference with Ria Health is that we're collaborative and that we're open to different treatment goals. And I think some people might criticize it as, oh, you're just enabling with this harm reduction model. But the reality is a lot of people would not come to treatment at all if they didn't have the option of reducing. And I'd say most of the patients who want to reduce are considering abstinence. And a lot of people after a couple of months decide, hey, you know what? They haven't been drinking a lot. They're feeling a lot better. And I always emphasize the benefits of not drinking. We talk a lot about negative consequences. How do people get here? An ultimatum from their partner. They're going to get fired. They have a DUI. Like humans, we're, sorry creatures in that we're motivated to avoid negative consequences. So when people get to a point where they're starting to notice the benefit of not drinking, that's when I say what's going to keep you sober in the long run is being aware of how much better you feel. Your brain works better, your energy is better, your relationships are better. And so sort of emphasizing the benefit. So part of it, I think, our openness. That's as an organization, Ria Health, we're very open. And we actually, everybody in the whole organization wants to hear what the patient's experience is and really work with people and treat you like an adult. I'll tell you what I think you should do. I mean, I'll give you a recommendation, but I'm not going to make you do it. But let's have a conversation and you can decide. I'll let you decide. So I think that is the biggest difference is autonomy and choice and cost. I mean, obviously, the thousand-pound elephant is that we're a fraction of the cost. You don't have to disrupt your work life. You don't have to disrupt your family life to go residential. And, some people need it. But I do think a lot of people come to us because they can't do an intensive outpatient program. They can't do 3 half days a week. So I do think the convenience we offer and the privacy we offer, and what we find, some people need a higher level, but we're at least willing to work with people on the front end to do it. So I would say autonomy and choice and having a partnership with your team.
Yeah, I agree with that 100%. I mean, coming from like inpatient and stuff like that in the past too, definitely travel was one of them, right? Getting away from family, it's not easy to do that, or work life. So I think that's where, like you said, we offer that convenience where you could kind of get treatment from your own schedule, which is great. Right. And cost, definitely. I think a lot of people that have never looked at treatment options and they come to us, they might assume sometimes that the cost is still too much because they're comparing us to like medication only type of offerings that are out there. But in reality, when you look at what we're offering, which is a similar level of treatment that you would get at an inpatient facility, the cost just is incredibly low, right? Especially if you're working with us, and we have a lot of in-network policies with insurance and other payers, so that could even offset any self-pay costs that you might have to incur. So that's another huge plus. But yeah, I think there's definitely a lot of differences. Another one I would say too is with a lot of inpatient models, like you mentioned, it's abstinence. And if someone fails, right, and they can't do full abstinence, it's really easy when I think we mentioned this in another podcast, but it's easy when you're in the inpatient facility because you can't drink. So you're technically abstinence right away. Right? But as soon as you go back out, I mean, there's so much more opportunity to relapse. And I think what ends up happening is people don't want to go to inpatient again a second time around because they feel like it didn't work for them. The reality could have been that maybe you had to take these baby steps. And I think, like you said, if we allow you to, start off with something where, it's moderation, sooner or later you will get to that abstinence. It's just only in that process down.
Yeah, frequently people aren't sure. And I think a lot of times I tell people, you don't need to know today what you're going to do. It's just, let's just get going on reducing and see where you're at, and, allow people to, based on their experience, and to make decisions. Like, again, like a grown up, like, we're going to let you make decisions based upon your experience.
Yeah.
Yeah.
Dr. Lindy, you mentioned a little bit about just harm reduction, and that's the approach that Ria takes most of the time. But I know you also have harm reduction experience from like different substances. What benefits do you see somebody, initiating their recovery through harm reduction?
Yeah, I mean, I think, well, I guess I'll start by saying that harm reduction kind of started with injection drugs. And it goes back now 30 or 40 years with things like clean needles, needle exchange programs. And the reason is pretty straightforward, is that injected drugs definitely associated with transmission of disease, HIV, hepatitis C. Dirty needles can cause skin infections, can cause heart infections. And that you had a lot of medical problems related to the needle itself. And so the other thing that I've noticed in harm reduction, and I work with stimulant users for a long time, is that when you change the route of transmission, you get less of an impact. So for example, when you inject methamphetamine, it kind of goes straight to your brain in a very high concentration. And that's why you see things like psychosis, meth psychosis with injection. It's a much higher rate of psychosis with injection. And so part of the harm reduction from a psychiatric perspective is if you smoke it or snort it, it'll still get to your brain pretty fast, but it won't be as concentrated. So it'll be a lower concentration. So you're less likely to have psychosis, less likely to be up for days, for example. So really the concept of harm reduction started with opioids and stimulants and injection drug users for the most part. It's a little bit later that we started applying it to alcohol, but I can say that there is a dose response in terms of alcohol's negative impact on your body. I mean, the classic organ we look at is the liver. Alcohol has a really adverse impact on the liver, in that there are some early warning signs of liver disease from alcohol. Elevation of your blood tests, so your liver enzymes are elevated. You can develop something called fatty liver, where you literally have a change in the structure of your liver that fat infiltrates. And then that can be a precursor to fibrosis, which is then you start to have structural changes of hardening of your liver, and then cirrhosis. I can say this for sure. If you come in and your liver function tests are like 2 to 3 times above the upper limit of normal, and let's say you're drinking 8 to 10 drinks a day, once you even reduce down to, I'm just going to pick a number, 3-ish, 2-ish, 3-ish a day, those liver function tests will come back to normal and your liver will regenerate. So that's one great medical health example of reducing by 50 to 75%. Your liver comes back to functioning normally. So that's from a liver perspective. The alcohol is obviously hard on our brains as well. So your risk for depression and dementia goes down the less you drink. It's very hard on our cardiovascular system. It's associated with high blood pressure and also atrial fibrillation, so an abnormality of the heart rhythm. I can't tell you how many times I've seen people who've gone from, let's just say 8 or 10 drinks a day down to averaging 1 or 2. And they said, my blood pressure, my primary care doctor is so happy because my blood pressure has come down to normal, or I was able to stop one of my blood pressure medication. So in terms of long-term harm reduction, really, a lot of it is in sort of a physical health or medical realm, that you begin to have less negative impact on your body and your brain with less alcohol. So now, there's a lot of momentum historically with abstinence only and 12-step and Alcoholics Anonymous, so that it's abstinence is the only way. And so it's been a challenge to kind of overcome that. And I'll be the first to give a lot of credit to 12-step and Alcoholics Anonymous. It works great for a lot of people. We have a lot of patients at Ria who still go to AA. But more commonly, we have patients who had a bad experience with AA. Some of them maybe didn't get it a fair shake, but it doesn't work for them. So we have people coming to us who just want a different approach. And so I think that the harm reduction has kind of a, negative connotation, but the way I think about it is abstinence is on the spectrum of harm reduction. Abstinence is sort of at one end of the spectrum of harm reduction. Stop drinking, you stop all the negative impacts on your body. So I absolutely feel like we need to meet people where they're at. I think there's a subgroup of patients that give up because they don't like or can't accomplish the abstinence right off the bat. So I don't see it as enabling. I see it as empowering patients to make a change. And like I said, a lot of people choose. They feel better and they're like, oh man. And the other conversation I have all the time is when you came in the program, you identified yourself as a drinker. And I'm hearing 6 months later, the way people are describing their approach to alcohol now. I said, it sounds like you identify yourself now as a non-drinker. And literally that's the behavior, that's the part that has sustainable, is when people then start to think of themselves as a non-drinker and alcohol subtracting and not adding to quality of life. And, I think what's interesting, which we really don't have a ton of data about longer term outcomes, but I'd be curious. But I mean, I see it over a period of 6 months to a year, frequently in that range, people become non-drinkers and for months at a time. Like people no drinks for 3 months, 4 months, and it's totally different. And so
that has definitely been the case for me. Like I started just like I wanted to be a social drinker, and now I very much identify myself as like a non-drinker. I just don't care for it at all anymore. And it's been 2.5 years at this point.
Yeah. And you can still be social without drinking alcohol. I mean,
I just threw a party at the gym Saturday. Like I had to organize it. I threw the party and I had 0 alcohol and it was fine. Right. I had fun.
Yeah. And I do hear people just this past week, I had somebody sort of remarking at how foolish the people who were drunk appeared to him as a non-drinker now. And in fact, he was referring to his family's Thanksgiving dinner where he didn't drink, but some of his relatives way overdid it. And he's just like, oh my God, did I really used to act like that? So anyway, and I'm not trying to be judgmental, but it's when you're not drinking, you're around people who are really intoxicated.
You notice it.
Yeah, it's different. Yeah. So I guess one question. So the last question I have is Ria Health essentially started in 2016. So it was started before COVID, but it already had that whole mindset of telehealth, right? So it was a virtual setting. I think COVID helped ramp up the business a lot more because a lot more treatment centers were kind of pushed to start doing telehealth services online. I think people got accustomed to it from their own physicians to, urgent care and so forth. So a lot's already changed, but I think there's still a lot more that could happen in the future. So I'm kind of curious, based on your experience, what's your vision for the future and how does kind of Ria Health fit into that vision as well?
Yeah, I mean, I've seen patients in person, obviously, when I worked at the medical school from, 2016 until COVID hit. And really, telehealth was kind of a novelty back then. People were talking about it. I did a little bit of it, but I was kind of uncomfortable with it. And when I came to Ria, I was still a little bit uncomfortable with it, although I did I'd say about 6 months, my last 6 months at UCSF, I was seeing patients in primary care via telehealth. So I got a little more used to it. And then when I came here, I got more used to it. So I guess I'll say this. One is, I don't think you lose much with a telehealth visit, particularly the kind of work that we're doing is more kind of like a primary care visit than a mental health visit. Having said that, a lot of the work that gets done is on that level of support, encouragement, looking at when you can psychological factors and mood and level of anxiety, looking at kind of psychiatric and psychological factors. You can do that on the video. I think in straight up therapy, it might be a little bit harder, although I've had a lot of patients do really well with teletherapy. And in fact, you can access it more readily. Your insurance company might contract with a telehealth provider to do straight up therapy. I think definitely telehealth is here to stay. I do think that the fact that we do telehealth allows us to provide better access. I think that is true. In fact, I'm now, I'm licensed in 10 states. When I started here, I was only licensed in California. And so it's actually kind of fun. I see patients all over the country. When I have a patient care day, I might see might have 10 patients and I might be going to 4 or 5 different states. It's actually kind of interesting. So I feel like it improves access and I don't see it as a barrier. I think it's here to stay. And I think what research has shown is that certainly in mental health and addiction treatment, it's still a big chunk of the outpatient visits. I think it's probably morphed a little bit. other specialties.
Dr. Lindy, this was so helpful and so insightful.
Yes.
I've worked with you for the last however many years, 4+ years, and I still learn so much from you every time you meet me. Thank you so much for all of your and answering all of our questions. Did you have anything to add before we end the podcast?
Well, I was just, from what you just said, I mean, thank you, to you guys, because I learned things from you as well. And I mean, we're partners. We do different things at the company, but I do feel that sense of collective action being integrated in lots of different pieces. And we really are, I hate that it's such a cliche, but it's true, mission driven, that everybody who works here wants to be here and really is on board with that. And then the last thing I'm going to say is, I learn a lot from the patients. I mean, I think that's the best part, as you go in with curiosity. And I'm always learning new stuff, even after 30 years, just by asking questions and being curious. And for me, it's sort of like seeing recurrent patterns, and I really learn a lot. And so it helps me when I see future patients. I'm hearing something I've heard many times before, and it really helps me put things together. So anyway, so thank you for having me on the podcast. And this is a great venture. So thank you for doing it.
Thank you for your time. And Arin, before we end this episode, is there anything you wanted to add? I think I heard we have a dry January.
Yeah. Thanks for reminding me. So we're doing what's called the Ria Health Dry January Challenge. A link to it in our description for the podcast. So if you visit howsmydrinking.show and you look at the podcast itself, in the description, there'll be a link to it. You could sign up. It's pretty cool. What we're going to be doing is we're going to give people tips and tricks, weekly videos from our coaches and other team member, and essentially kind of help them in that progression. So if there's anyone that's interested in trying Dry January for the first time or has done it in the past, hasn't really been successful at it, it is a free resource that we're offering anyone, right, that they could join. So try to sign up before January 1st, obviously, because the challenge is going to start on the 1st of the month. And
Awesome. Thank you, guys. We'll talk to you next time.
Thanks. Bye.
Thank you.